Hello, and thank you for viewing this poster and its accompanying talk. My name is Dr. Peter McGran, and I hope today to talk to you about some of the salient points around my research to contextualise it within clinical practice. Firstly, endonasal surgery is a relatively recent emerging field of practice for surgeons. It feeds into three more traditional subspecialties: neurosurgery, ENT and ophthalmology, and it is the use of endoscopic tools to approach the brain, the orbit and the sinuses. These techniques have become possible due to the emergence and increased availability of CT or computer tomography. Computer tomography has allowed appreciation of the variations that are found within an individual patient to best allow for pre-operative planning and make the procedure safe enough to be worth the risk to the patient. So the anterior ethmoidal artery is one of those key variants that need to be recognised prior to surgery. The anterior ethmoidal artery, in its short course, traverses three bodily cavities. It emerges from the ophthalmic artery and crosses the orbit into the cranial fossa, where it then enters the sinonasal cavity. Due to the nature of how an artery will respond to inadvertent injury in the live patient, the artery will contract both in its diameter and along its length. Therefore, the proximal end of the cut anterior ethmoidal artery will retract along its length through those three bodily cavities previously described. As a result, there is the possibility that the anterior ethmoidal artery will be in the orbit where it can't be reached by the surgeon and still bleeding. If it is still bleeding, the increased pressure within the orbital cavity will result in loss of vision on that side if not quickly remediated. Furthermore, due to the nature of how it would retract, the meninges would become inoculated with bacteria from the sinonasal cavity, and also there is a risk of cerebrospinal fluid leak due to tear in the meninges. These are obviously major complications that a surgeon would be keen to avoid, and why this is such an important area to recognise prior to any surgery in the area. My work highlights basically is a systematic review. The reason that it was a systematic review and no novel research is that due to the pandemic, CT availability became impossible to me at the time, and also I wasn't able to access any cadaveric specimens either. However, I do think that the systematic review does contribute to the current body of knowledge, as there's been recent emergence in new nomenclature and obviously new papers since any previous work had been done. Key points that I think the work, the results are in the poster itself. The key points I'd like to make are that the lateral lamella is a useful correlation for the anterior-posterior position of the anterior ethmoidal artery. Other than those, these were originally highlighted by Mesoklinger, the lateral lamella, and 75% of cases, the anterior-posterior position of the artery as it intersects these lateral lamella was between the second and third lamellae, and a further 22% of cases were found within the third lamella. The supraorbital ethmoidal cell is not universally found in all ethnicities. It is primarily found in Northern Europeans. It is a relatively recently named structure. It is ethmoidal pneumatization along the side of the orbit, and it affects the course of the anterior ethmoidal artery. The anterior ethmoidal artery, if a supraorbital ethmoidal cell is found, the anterior ethmoidal artery is likely closely adhered to the supraorbital ethmoidal cell, and also it is more likely to be separate from the anterior ethmoidal artery, is more likely to be separate from the skull base, which leaves it more open to injury. So therefore, if a supraorbital ethmoidal cell is found, it is important to highlight that the anterior ethmoidal artery will be at high risk in this surgery. as I alluded to earlier, there's been recent emergence in new classification systems for the nose to better aid communication between disciplines and research. So the international one I'd like to highlight is the International Frontal Sinus Anatomy Classification, which has emerged in 2016. Was a consensus document between endonasal surgeons to discuss the pneumatization patterns of the frontal sinus. This is an area I think where we could help. Obviously, the anterior ethmoidal artery is closely associated with the frontal sinus in its course, and to better aid communication and understanding of novel research, I think this would be worth adopting in future novel research into the variability of the anterior ethmoidal artery. Also, I feel that there's a lot of increased availability of CT scans for research. These have the benefit of directly translating into clinical practice and would be a good area for further research into the anatomical variance of the sinonasal cavity as a whole. So that's all I would like to say. Thank you very much for your time.